Hello, everyone. Um, this is a voiceover that I have been thinking about doing for quite some time. I guess the only reason I didn't do it is because there was just not a whole lot of time in the day to get to everything. We did actually go over fluid and electrolytes and parenteral therapy when we were in class. I think we had like maybe three topics that we had to go over that day. And some of the questions that was coming forth, not that I'm criticizing you guys for, but it was kind of one of those situations where some students really wanted to really know the information before moving on to the next slide, if you will. And that took a lot of time. And so we lost a lot of time in doing that. And one big reason that happens is because, as I said before, and I'll say again, if you're not reading, then when this information comes to you for the first time, it is going to be very challenging for you. So, you have to do yourself, do me, do your cohorts a favor, and make sure you come to class more prepared. And then that way we're not holding up progress, if you will. Again, not trying to throw any shade or anything like that. But the reality is we have a lot of information and we can only spend so much time on it. And as you guys know, I do like to spend as much time as possible, but realistically speaking, I can't spend but so much time on some of these concepts, if you will. So anyway, I know you guys have a test tomorrow, and hopefully you have been reading this chapter. We got so far in this particular presentation, but I'm going to go ahead and start at the beginning. I mean, you might as well start at the beginning. I think I may have been on slide maybe 15, 16-ish or something like that. But again, I'll go ahead and just start from the beginning. At the very least, if you guys haven't really gotten to this particular chapter yet, because I know some of you are really still studying now, then at least if it's on the YouTube platform, you can actually speed up this presentation. So if it takes me a couple of hours to do this, you can probably make it or listen to it in maybe an hour. And I'll make sure I put that in an email so that you know that that is an option. Kind of that last minute preparation, if you will, just before your exam 2 pharmacology on tomorrow. All right, so let me go ahead and start sharing. So give me a moment. Oh, it's the wrong link. Let's see, window. And I think that's the one I want. All right. So I should be sharing at this time. Let me go ahead and open that up a little more. And we'll go ahead and get on this thing. All right. So let's, so first of all, again, this is Introduction to Clinical Pharmacology, and we're looking at Chapter 54, Fluid Electrolytes and Parenteral Therapy. This is going to be one of the really important tasks that you will encounter as a professional nurse. And this particular treatment has harmed, even caused the death of many, because if the nurse is not savvy, if the nurse is not knowledgeable in the administration and management of fluid and electrolytes and parenteral therapy, it can cause these patients a lot of problems. And so one of the reasons why I prefer to go ahead and start at the beginning. And of course, if you were in class already, because I think there was quite a few people who weren't in class when I went over some of the information. But if you were in class, you can, fast forward to where you believe we stopped off, and I may be able to tell you at some point in the email where we stopped off, and if you wanted to start at that point, you can do that as well. All right, so take a look at the learning objectives. We have list the types and use of solutions used in the parenteral management of body fluids. Let me make sure my volume is up. All right. All right. Define the steps involved in the intravenous administration of a solution or electrolyte used in the management of body fluids. All right. And describe the calculations used to establish IV flow rates. And much of this is also in the PowerPoint as well for you to take a look at. Compare and contrast the types and uses of electrolytes used in the management of electrolyte imbalances. And remember, this is what it's all about. Our bodies must be maintained in that homeostasis, function, if you will, in order to operate in a way that the body's essentially is healthy. Basically, I guess is what I'm trying to say. So fluid and electrolytes is a very important part of health and human health, and therefore sometimes in sick states, these patients, they have an imbalance of their fluid and electrolytes, and it's up to us to try to reestablish that balance in order to maintain that level of health, if you will. All right. Explain more common signs and symptoms of electrolyte imbalance, and this is kind of where the challenge comes into play, because you have several electrolytes that we deal with. Mainly, you have your potassium, sodium chloride. Sodium chloride usually goes together. If the chloride is low, then the sodium is likely going to be low. If the sodium is high, the chloride is likely going to be high. Those are two electrolytes that bind together. And so magnesium, if I didn't say, calcium, if I didn't say, there's there's a number of electrolytes that we speak of, and in particular, hyper and hypo. All right, there can be a hyper calcemia or a hypocalcemia, meaning a high or low calcium level. A hyperkalemia, a hypokalemia. So try not to get those confused. There's a hyperphosphatemia, meaning a high phosphate level, and there's a hypophosphatemia, a low phosphate levels, and there's signs and symptoms that goes with each of those. Now, we typically look at those by systems. For example, how does the potassium, high or low, affect the neurological system? How does it affect the cardiovascular system, the respiratory system, the GI system, and the musculoskeletal system? Those are the main systems that we're concerned about with respect to electrolyte imbalances. And one reason it's important to do it by systems is because, for example, if you're looking at a patient who has a hyperkalemia, meaning there's an increase in potassium level, then you automatically know one of the main systems that would be impacted will be the cardiovascular system. And we always want to place those patients on a cardiac monitor, whether it be a high or low potassium, high or low magnesium, high or low calcium, and so forth. We always want to place these patients on monitors, cardiac monitors. And cardiac is just one system. It affects other systems as well. And you have to be able to do a physical assessment on those systems, because these electrolytes, they affect those systems in certain ways. Like, for example, if someone has hypokalemia, they may have depressed respirations. All right. And so that would be an important part of your assessment. All right. So that's pretty much what I mean. We'll delve more into that as we get into the discussion. And then, of course, the pre-administration. I don't think I'm going to get to this part because it's quite, this will make this presentation quite long. I want to say it's like 70 something slides total, but maybe 50 something without me delving into that part of it. All right. But you should still read it. List a nursing diagnosis particular to a client receiving electrolyte or a solution to manage body fluids. And of course, examine ways to promote an optimal response to therapy and important points to keep in mind when educating clients about the use of electrolytes or a solution to manage body fluids. So make sure you guys take a look at that. I'm gonna go ahead and, all right, so some of this, at least in the beginning, I'm going to maybe take my time just a little more with it, just to make sure you really got it behind this. Yeah, just to make sure you guys really got it. All right. Now, so facility policies, state laws, and also the Nurse Practice Act does govern your involvement in the administration of fluid and electrolyte management. Now, no matter what the practice setting is, be that the acute care setting, a long-term care, or home setting, it doesn't really matter. It is important for you to have a really basic understanding of fluid management and administration. Now, this particular chapter will give you guys information about body fluids and also electrolytes, as well as basics on parenteral therapy, meaning IV. Whenever we say parenteral, we mean IV therapy. All right. Now, fluid makes up a major portion of our body tissues. So over 70% of the body is made up of 70, excuse me, over 70% rather, of our body is made up of fluid, which is quite a bit. It's even more when you are a child, of course. So take a look at figure 54.1 for that illustration. It gives fluids essentially give our cells shape. The intracellular part of the cell, inside of the cell, fluids give it shape. If our cells did not have fluids, they would look rather shriveled up. Right now, the fluid also acts as a cushion by filling the void between cells, which is referred to as interstitial. Interstitial is that area, of course, where when fluids from the vascular space leaks into the interstitial space, is what causes edema. All right. And also, this fluid travels throughout our bodies with elements to help cells work or eliminate waste and the way of, and with speaking of plasma, if you will, this is the fluids and that travels, that plasma, part of the blood. Now, when individuals become ill, they may lose excess amount of fluid or not feel well enough to maintain daily intake of fluid needed for basic survival. All right, you need it for basic survival. Now, without fluids, the body's ability to transport oxygen and nutrients to the various tissues does become compromised. Now, individual cells or organs are not able to function, and the person can become even the more ill. Now, various solutions are used in the management of body fluids, and these solutions are used when the body cannot sustain the fluid and electrolyte balance that is needed for normal functioning. All right. And as you can see here, in terms of why we need IV fluids, IV fluids or parenteral, they are parenteral source of electrolytes, calories, and also water for hydration. They also facilitate nutrition and maintain electrolyte balance when a patient cannot eat. There are certain conditions, like if someone has a paralytic ileus, meaning the intestines are not mobile. Their peristalsis is significantly decreased if you have any at all, or an obstruction, or maybe if there's a fistula within the GI system. These patients would not be able to eat, and therefore we have to maintain their fluids and nutrition, their electrolytes, in another manner. And the parenteral route is the way to go until hopefully the person gets better. Also, it's the method to deliver drugs when a less invasive method is not suitable. And so this is the importance of IV fluids. All right, I just talked about that. I guess I kind of got a little ahead of myself. All right. Now, all facilities have specific policies and procedures for cleaning, for access, and also stabilization of IV sites. Right. Remember, this is an invasive procedure that is being done here. A patient can develop an infection if these sites are not properly maintained. Right. Now, no matter the facility, there are some basic guidelines you should be aware of regarding IV access. All right, now let's go over some of the basic guidelines. The non-dominant arm is typically chosen when selecting a vein for an IV because remember, if we tend to use our dominant arm when doing different tasks, and if the IV is placed in that particular arm, then the IV might be compromised. So it's better to put it in an IV, or excuse me, in an arm that we use with less frequency. Sites are often chosen starting at the most distal point of the arm. So you start near the fingertips and you work your way towards the armpit. Now, larger, more proximal veins may be selected depending on the need for the IV therapy. Somebody's getting blood, if somebody's getting some kind of contrast medium, and anything that, any fluids that tends to have a thick a texture, if you will, or consistency is actually the right word, a thickness to it. We tend to use much larger veins. It just makes it easier to administer the IV therapy that way. Now, IVs are never started on the same extremity as renal dialysis access device or mastectomy. So we have to ask about extremity restrictions, and just doing a history and physical on your patient could make you to know that I can't start that IV on the left arm or the right arm because the patient has an AV fistula for dialysis, or this young lady has had, or this lady has had a mastectomy. Now, ask if providers have remarked or noted issues before such as a bifurcated vein. When veins are bifurcated, they actually split, right? And we have to be careful about inserting an IV in these types of veins because they're not as straight and easily accessible as the veins that are more straight, if you will. Now, following these guidelines can save time and also reduce pain of an unsuccessful attempt when the client's knowledge of previous care is considered. And so if we do not consider these basic guidelines, essentially what we're saying is this patient, you might end up sticking this patient several times, and that can cause an undue amount of pain that we shouldn't see. So be really careful about following these guidelines. As far as equipment is concerned, selection of equipment will depend upon the use of the IV access line. Larger gauge needles are used with rapid infusion. So somebody comes in with a burn, we need to get fluids in them very quickly. And so we don't need one of those very small needles, if you will, or angiocaths is what we refer to them. Or large amount of fluids or blood products are also anticipated that we would need a much larger gauge. Indwelling devices are used when a longer duration is anticipated compared to only a few doses. And so if we're going to be using this IV access device, for example, somebody's on TPN, they're going to be on for a very long period of time, we need to get an IV access device that can endure over a longer period of time. Now, tubing selection will also be dictated by whether the IV will run fluids continually, or occasional access over the period of a day. And so, we select tubing just depending on the situation or circumstance with the IV fluids that we are administering. All right. Let's see. All right. All right. So let me go ahead and then move on. All right. So now up here, you see where it says intermittent intravenous access. You see this device here. You don't see. This is what we typically would call an INT, right? And basically, we use it intermittently, right? And so, as you can see, there's no IV tubing connected to this. And so this is where, for example, if a patient needs an IV antibiotic every 4 hours, then we would access it. We would use the tubing, the usual tubing to administer the IV antibiotic. And then we would disconnect it, flush it, and then, of course, this little white piece here is how we would not cap off, but basically close the line off so that, we can protect it from inadvertently administering something through that IV device. But this is basically used for intermittent use. We use it for IV push medications. This means that you take a syringe of medications, like, for example, Solu-Medrol or IV low pressure. We'll give it over a certain period of time, and then we're done, and we flush it. We flush it always before and after. You may flush it with heparin or sodium chloride or normal saline, and normal saline is more preferable. Heparin will probably keep the line open or patent much longer, if you will, but the normal saline is the usual fluids that we use to flush it and keep it open. So we flush before, give the medication, and then flush afterwards. Kind of like what we do with an NG tube or a feeding tube. We flush it, we give the medications, and then we flush it again. So same thing with an IV. With this INT, it does make it easier for the patient to ambulate and move about because they're not tied down to the bed with this IV tubing keeping them connected. So a greater ability to be mobile. Patency is maintained with saline and heparin, and I've already said that. Didn't even see that, but anyway, yeah. And as I said, normal saline was what you will see even the more. All right, so as far as continuous infusion access, and so as you can see here, you see these IV tubing that is here. So just picture this IV access device here, but now we connected some tubing to it. All right, to that, and so that makes it more continuous. And as you all can see, the pump here. It is used for replacement of fluids. Sometimes a patient might be dehydrated. They may be NPO for a pretty good period of time, and so they need the IV fluid so that they won't experience that fluid and electrolyte imbalance. Also, if there's frequent drug administration, we want to have a continuous IV fluids going. Let's say normal saline at 10 cc's per hour. That's really minuscule. That's not that much at all. But I would usually keep that running continuously while I keep on bringing that secondary IV push, antibiotics or other medications. I can keep just switching it out instead of having to go to that INT on the previous slide and keep flushing it, before and after. And well, don't like to do all that. I prefer to just hang an IV fluid solution, normal saline, which matches our body's internal plasma. It's an isotonic solution. It doesn't really hurt the patient at all. So I would just keep something like that going. And then if I got, let's say, several drugs that I need to hang in the bag, that becomes my secondary, IV push and whatnot. Not IV push, but my secondary IV that I would use to administer the medications to these patients. Just makes your life a whole lot easier. And I was trying to show you guys this when we were in the lab. And so reach out if you don't remember, if I need to show you again. Drug administration. Also, electronic infusion devices are often used to monitor the rate and flow. So you guys are learning how to do this manually now, but I will tell you that, and unfortunately, if you don't use it, you lose it. When you get into these facilities these days that have these particular pumps, then you can program the pump to give the drip rate that you want, because it'll have all that information on the label. But you still have to learn it. So, which is a good thing. You may go to one of those rural hospitals where they, don't have this kind of technology. You have to do it by hand. So keep your skills up as much as possible. So don't sell your hanky textbook, in other words. In terms of calculating intravenous flow rates, IV fluids are administered with the following information. We need the volume to be delivered. We need to know the time in hours or minutes, but usually we take the hours and convert them to minutes. Also the rate. We have milliliters per hour, milliliters per minute, or drops per minute. And so it all depends what the order is. Now, if IV solution is not being delivered on a pump, the drop factor will need to be calculated. And so tubing comes in different drops per ml, 15 drops per minute, or drops per milliliter. And so you have to use these different numbers in your, in your calculation. So you guys know how to do that. I think we did that with you all in class the other day. So take a look at this particular example here. All right. They may give you one on the exam. Take a look at that one. So the previous one is a drop factor of 15. So you got to use that number. All right. And you see how it says 60 minutes. So you essentially say if it's 8 hours, so 60 times 8, and that would be the minutes that you would use. All right. And here there's a drop factor of 10. All right. And so just make sure you guys are doing your calculations just in case. Now, fluid overload. So this is an adverse effect of all IV fluids that occur due to the IV administration of the rate being greater than the body is able to use or eliminate fluids. So sometimes a patient may have heart failure or some kind of cardiac condition. They may have kidney or renal issues where they're not excreting fluids, if you will. And so they develop just what you see in this picture here. This appears to be a pitting edema. Can hardly tell because I don't see where the indentation in the skin is shown in this picture. All right. But we have to assess these patients. We have to know what their history is, and we have to know if they have a cardiac history, if they've had a coronary artery disease or heart failure, if they've had an AMI before, an acute myocardial infarction. So we have to know if they have cardiac issues, because if you give them fluids too fast, the body is not able to handle it, you got a problem. All right. So fluid overload is never any good. It can result in pulmonary issues because fluid begins to back up in the heart, goes into the lungs, and causes pulmonary edema. All right, so solutions used in the management of body fluids and electrolytes. So we use intravenous replacement fluids, which we will get a chance to look at some of those. We also give blood plasma to these patients. We give, especially when their hemoglobin and hematocrit values are low. We get blood plasma. We also get plasma protein fractions. Remember, the liver makes proteins, and sometimes the liver is diseased, or maybe nutritional wise, they're not taking in enough proteins, and therefore we have to replace them. If we do not replace their proteins, then the liquid or the plasma part of the blood tends to leak into the interstitial space, causing pictures like this. All right, fluids are leaking into the interstitial space. The proteins help maintain or keep that liquid part of the blood in our blood vessels, in other words. There's also plasma expanders, and they give these types of fluids when someone comes in with really severe dehydration or severe blood loss. For example, patient comes in with burns. I mean, they're losing all kinds of fluids, and we have to expand that vascular space with this type of fluids or plasma in order to improve their blood pressure. Otherwise, if their blood pressure is too low, then they're not going to be able to perfuse the rest of the body adequately. There's also TPN, total parenteral nutrition, and this is what we give. We feed patients IV. This is a picture I showed you in the classroom, the yellow looking fluid, and also the white fluid in the glass bottle. We feed these patients when the GI system cannot be used for whatever reason. Intestinal ileus obstruction, intestinal obstructions, and fistulas within the GI system, some bleeding within the GI system. So we have to feed them a different route until we can figure out what's going on, until we can heal or fix these patients. The fat emulsion lipids is what is usually given with the TPN. The reason they give lipids is because they want your body to break down the lipids for fuel, as opposed and spare the proteins in the TPN. You want to spare the proteins because you want the proteins to be used for healing. Otherwise, if we didn't use the lipids, then the body would turn directly to the proteins in the TPN, and then healing would be much more difficult for these patients. There's also alkaline and acidifying agents that are used. Sometimes when the patient's blood becomes acidic, they may hang IV fluids with bicarb or alkalining solution in order to make the blood more or less base, right? So they're more acidic. You hang these bicarb solutions, and you want them to be, or the goal is to achieve that 7.35 to 7.45, basically. Let's see. Where am I? All right. And by the way, the plasma protein fractions, they're used to treat hypovolemia, a low blood volume. When someone particularly has hypovolemic shock that occurs with burns, as I mentioned, trauma, surgery, and also infections, or in conditions where shock is not currently present, but is likely to occur. So preventative prophylaxis. All right. And I want you to pay attention to the adverse reactions for this particular IV fluid, the plasma proteins. Although rare, it does happen. All right. And so just make sure you are looking for those signs and symptoms like nausea, chills, fever, urticaria, and also hypertensive episodes. So take a look at that. All right. There's also some contraindications for plasma proteins, especially those who have a history of allergic reaction to albumin. Severe anemia. They have severe anemia, cardiac failure, and so forth. And so there are some contraindications. Make sure you guys read that. Those are the weeds I'm trying not to get too involved in because it takes much longer. Now, as far as electrolyte imbalances, this is what I was explaining to you earlier as far as the learning outcomes. So you have potassium, magnesium, sodium, and calcium. potassium, magnesium, sodium, and calcium, high or low. The hyper is high and the hypo is low. And the key here is to know how it affects different systems. I would probably focus more on what happens neurologically, pulmonary, and cardiac. Even though GI and musculoskeletal is important here, but I would focus on those systems mostly. All right. All right. So take a look at potassium. What does potassium do? So it's necessary for transmission of impulses. So it's how nerve impulses travel, if you will. It is also involved in contraction of smooth cardiac and skeletal muscles. Remember the different systems I told you about. All right. Um, and this is why we tell you when the patient has hypokalemia, for example, or even hyperkalemia, we have to place them on a cardiac monitor to see if it's causing any kind of abnormal rhythms, all right, which can affect your cardiac output, by the way. Sometimes hypokalemia, I think that's the one that can cause a weakness in the musculoskeletal system. Now, we use this particular electrolyte to prevent or treat hypokalemia due to loss of GI fluid. Somebody might be throwing up a lot, vomiting. Also in diabetic ketoacidosis, remember in DKA, patients are initially hyperkalemic, and then as the body begins to diurese all that sugar, it loses potassium also. So we want to, and then they turn to, or they develop hypokalemia, and so we need to replace that. Also diuresis, when we give a patient a diuretic, especially a loop diuretic, such as furosemide, or you guys also know it as Lasix, we lose potassium or electrolytes as well. Even magnesium, calcium, we lose electrolytes. So this is a very important chart here, the actions and uses. Magnesium plays an important role in transmission of nerve impulses as well, and also enzyme reactions. We need it for enzyme reactions. We use it to treat hypomagnesemia, and so you guys need to know the difference between hypo and hyper. If we're talking about somebody's in hypermagnesemia and they're trying to give magnesium, that's contraindicated because the patient is already on the high side, and if their magnesium is low, then why would you be giving it, right? Unless you're just trying to maintain it because they have some condition where they are losing magnesium, and you're just providing a continuous infusion to make sure it doesn't, drop too low. We also use it in the prevention and control of seizures, and especially obstetric clients with pregnancy-induced hypertension or eclampsia. So we give mag sulfate in order to minimize their risk of seizures. We also put this electrolyte, this ion, also called an ion, in a TPN as well. We can put all these electrolytes in TPN, by the way. Right. And we measure this by milliequivalent. So you'll see MEQ, like 40 milliequivalents in 20 mLs and what have you. All right. Now, nasogastric suctioning, drainage of intestinal fistulas, diarrhea, vomiting, and so forth can also lead to low potassium. So in other words, if you have a patient on or has an NG tube, or maybe they're having a lot of NG tube where you're suctioning contents from their GI system, they can become hypokalemic. If they have a fistula, which is like an opening within the GI tract that leads to another body cavity, right? They can also, just the drainage itself can cause them to lose a lot of potassium. So DKA, we talked about that. Initially, you're hyperkalemic, and then because of the diuresis, the body trying to get rid of all that glucose, they become hypokalemic. So just make sure you take a look at that. Severe malnutrition, because remember, our electrolytes are, we obtain electrolytes from our diet. All right. All right. Potassium is an intracellular electrolyte, meaning you will find much of your potassium inside the cell. You do have some on the outside, but it's mostly, you'll find much of it is inside the cell as well. Right. So you have some in the extracellular space. Whenever we draw blood on patients to try to ascertain their potassium level, we are getting this serum potassium level. So that potassium that is on the outside of the cell. But again, potassium is known to be within the cell as well. All right. Now, adverse reactions to potassium. These patients may experience nausea, vomiting, diarrhea, NVD, abdominal pain, as well as phlebitis. In terms of adverse reactions with magnesium, these patients may experience flushing, sweating, as well as hypotension. They also have depressed reflexes, muscle weakness, respiratory failure, and circulatory collapse. So make sure you remember especially the depressed reflexes and muscle weakness, and also the respiratory failure. Though that is something you will likely see on an exam, by the way. Right. Adverse. Now, something else that is worth mentioning is that when potassium is given IV, it's very strong. It's very irritating. It can cause phlebitis of the vein um, when administered IV. It can also, let's see, why does this say phlebitis have been seen with oral? So they talk about how phlebitis is seen if it's given oral or IV. I'm not sure about the oral, but I know IV administration of potassium can certainly lead to phlebitis, irritation of the vein. Now, potassium, of course, is contraindicated in patients at risk for hyperkalemia. You'll see where I put like an arrow, an up arrow meaning increase, and K plus meaning increased potassium or hyperkalemia. Kind of do that to create less verbiage or words, as you visualize this. If a patient has a renal failure, oliguria, azotemia, remember these are conditions that you see in renal failure. Remember, one of the functions of your kidneys is to help maintain fluid and electrolytes. If you got too much potassium, then the kidneys will excrete that potassium. If you don't have enough, it'll try to hold on to potassium. But if someone has renal issues, oliguria means that they're not really excreting much urine, and so they're holding on to some of these electrolytes. You want to make sure that you're watching those values, those lab values, because you don't want to send them into a hyperkalemic state. Someone has anuria. They're putting out like maybe 100 cc's per 24 hours. Also severe hemolytic reactions. When someone has a hemolytic reaction, meaning, in other words, sometimes when patients are getting a blood transfusion, one of the negative reactions of a blood transfusion is that it causes the red blood cells to burst. And when those red blood cells burst, you're dumping a lot of potassium into the system, right? Because potassium is within the cells. And so this is why when you're giving blood administration, you have to look out for those reactions, blood transfusion reactions, and severe hemolytic reactions are a part of that, along with some other issues. Also, if there is untreated Addison's disease, acute dehydration, heat cramps, and any form of a hyperkalemia, we want to be careful about giving potassium. Acute dehydration would be dangerous because, remember, with dehydration, the blood is already concentrated. And so if you give these patients potassium, then the potassium values are going to appear really elevated. So you have to really hydrate these patients. and continue to monitor their potassium levels. All right. Patients with heart conditions, metabolic acidosis, severe, prolonged or severe diarrhea, we must be careful about administering um, potassium. Also, patients who take ACE inhibitors, typically with ACE inhibitors, it causes us to excrete sodium and water, but we hold on to potassium. And so, if you're giving these patients potassium while they are receiving an ACE inhibitor, we use ACE inhibitors to lower the blood pressure. And this is by preventing the conversion of angiotensin 1 to angiotensin 2, something we talked about. So with this drug, patients tend to become hyperkalemic, and so you don't want to give potassium medications when they already are at risk of hyperkalemia. Also, keep in mind that sometimes patients, they take these potassium sparing diuretics like spironolactone, or we also call it aldactone. Um, those medications are potassium sparers. In other words, they hold on to potassium. They're not a potassium waster like your Lasix, right? Or your loop diuretics. Your loop diuretics, the thiazide diuretics, you tend to excrete a lot of your potassium. But with these potassium sparing, they spare loss of potassium. So you don't want to give administer potassium when somebody's already on a potassium sparing electrolyte or diuretic rather, because that would only increase their potassium levels. Also, salt substitutes. Now, this will fool you because you're thinking, well, it's not salt like sodium chloride that I'm putting on my food. I'm just using a salt substitute. Well, salt substitutes have potassium in them. And so if someone is already on an ACE inhibitor where their potassium levels are increasing, and you place them on a salt substitute because you think you're helping their, let's say, heart failure condition or their hypertension, where you don't want to make it worse by, giving them salt. Wherever salt goes, water goes, and that can worsen hypertension. It can worsen heart failure. And so sometimes people might think a salt substitute may be the best other option, but it isn't. You have to choose some other options, in other words. Also, the use of digitalis with potassium increases the risk of dish toxicity. What that means is that there are patients who are on a medication called digoxin. Digoxin helps the heart muscle to contract stronger. And if a patient has a low potassium level, it can cause a dish toxicity. All right. So we have to make sure the potassium levels are normal. All right. I feel like I really had to kind of go through that one because those are very particular to potassium. All right. And again, make sure you read the rest of this information. I'm just trying to see adverse reactions from magnesium administration, the most likely related to overdose and may include flushing, sweating, hypertension, depressed reflexes, muscle weakness. I think I said that respiratory failure and circulatory collapse. It is contraindicated in clients with heart block, myocardial damage, and also in women with pregnancy-induced hypertension during the 2 hours before delivery and whatnot. So again, take a look at that. Let's see. So I talked about this already. I guess I kind of got ahead of the game, and we pretty much explained what this is all about here. Again, think about your kidneys and think about what their jobs are. The job is to maintain fluid and electrolytes, and if you um, um, have a compromised renal system and you're not excreting or you're not able to absorb electrolytes appropriately, like a normally functioning organ, then you can end up with too much of these electrolytes. So be careful. All right, so when we give potassium with an ACE inhibitor, and remember the ACE inhibitor is used to treat hypertension here, if there's a risk of hyperkalemia. If we give potassium with a potassium-sparing diuretic like spironolactone, which is used for patients with heart failure, because you're trying to, the thing about heart failure is that we try to use these diuretics like a loop diuretic, furosemide, torsemide, Bumex, in order to try to relieve the patient of the excess fluids, right? And so what happens is when we're giving those diuretics, we sometimes cause hypokalemia because with all the fluid loss, they tend to lose, these ions of the potassium, magnesium, calcium as well. And so instead, they'll place them on a potassium-sparing diuretic in order for them not to lose their electrolyte, this particular electrolyte. Now, of course, with the diuretic, not the spironolactone, but your Lasix type of diuretics, they may place the patient on, give them a supplement, a potassium supplement with the diuretic. But in this particular case, they're just trying to avoid the patient developing hypokalemia. All right. And if you give potassium and this potassium sparing diuretic together, hyperkalemia, if potassium is given with digoxin, which is used to treat cardiac disorders, there's a risk of dish toxicity. So very important to know. Let's see, we talked about this one already as well. Use cautiously during pregnancy. It is a category A, meaning, we can give it, but just with caution. And also with renal function impairment, we have to be careful. Again, think about or go back to your kidneys and what they do. Magnesium interactions. Let's see. So when we give magnesium with some of the central nervous system depressants, and those depressants would be like your alcohol, your antidepressants, your antipsychotic drugs, and these are used for different reasons, for social enjoyment, the alcohol, antidepressants for the depression, and the antipsychotics for psychosis. It can increase the CNS system depression, or increase in CNS depression can occur. So this can also affect these patients' respiratory system, what causes lethargy and even perhaps even coma and whatnot, because it's depressing the system. Also, if we give it with a neuromuscular blocking agent, which is a drug we use to paralyze patients when we're putting a tube down their throat, like an intubation tube, to place them on a ventilator, because otherwise they'll fight and resist, and it's really hard to intubate them. And so if you give this drug with these blocking agents, it can prolong respiratory depression. All right. And so, of course, if they're on the ventilator, it really kind of sort of doesn't matter because the machine is breathing for them. But if you're trying to wean them, then you have to back off of the magnesium, because otherwise they won't be able to come off of the ventilator. Digoxin is used to treat cardiac disorders, and it can lead to heart block. All right, sodium. Sodium is important in maintaining acid-base balance. There's several things. Normal heart action. So this is, so again, place them on a monitor. Also regulation of osmotic pressure in the cells. And so we use it to treat those patients with low sodium levels like hyponatremia due to excessive diuresis. We may be giving them too much diuretics, wherein they are just excreting just too much sodium. Also, we use it to treat severe vomiting, diarrhea, also diuretic use, and wound drainage. All that drainage, you're also draining just quite a bit of sodium as well. So that's why we would give sodium. As far as calcium, calcium is used for necessary for function of nerves and muscles. And remember, nerves and muscles go hand in hand. Nerves stimulate muscles to move. All right, not the other way around. We also use calcium for clotting of the blood. The body needs calcium to help with clotting, so people don't bleed to death. Building bones, of course, that's a given, and also teeth, and also other body processes. And so we give this medication to treat hypokalemia. Uh, can also occur with parathyroid disease or removal. So remember the parathyroid, not the thyroid, but the parathyroid that sits behind the thyroid gland. It helps to maintain um, what is it? Phosphorus and calcium. All right. And if the phosphorus levels are high, because there's an inverse relationship, the phosphorus levels are high, then the calcium is low. And if that's the case, if the calcium levels are low, then we need to give calcium. All right. Because otherwise, they can lead to many problems, especially respiratory and cardiac issues. And also is given during CPR. And this helps to strengthen, you're trying to strengthen contractions of the heart, myocardium. All right. Now, in terms of the extracellular electrolytes, so this is what we're saying is this particular salt, if you will, is outside of the cell in the extracellular space. Adverse reactions, hypernatremia, high sodium levels can occur, especially when you're trying to replace it. They typically, if someone, let's say someone comes in with hyponatremia, we place these patients on a sodium drip. The sodium drip is like 3%. That's very concentrated. You have to really be careful with administration of this IV fluids because it can throw them into on the higher side. All right. Excessive oral use may cause nausea and vomiting as well. As far as adverse reactions to calcium, these patients will experience irritation of the vein. So when we are administering it IV, make sure you try to administer it in a large vein, potassium, calcium, and use a large vein like in that bend, the bend of the arm. We call it the antecubital area, if y'all can see what I'm doing on the camera. Let's see. So another adverse reaction is tingling, metallic and chalky taste, and they also may experience heat waves. Now, rapid IV administration of calcium gluconate can cause bradycardia, so it's more of a depressant effect. It causes bradycardia, vasodilation, decreased blood pressure, and also cardiac arrhythmias that may lead to cardiac arrest. And so they depress the cardiovascular system. Oral administration results in GI disturbances, and so sometimes the GI system doesn't tolerate it very well. Administration of calcium chloride, it can cause peripheral vasodilation. Sometimes we give calcium like a calcium channel blocker to block calcium from going inside of the blood vessels to dilate it or relax the blood vessel. If we relax the blood vessel, it causes the blood pressure to be lower. All right, so we do that, for that reason sometimes. It can also cause a temporary fall in blood pressure, so we need to monitor that, and also localized burning, what could be another issue. Let's see. Let's see where I am. Extracellular. Let's see. That's. All right. I think I went too far ahead of myself. All right. So again, we talked about sodium being in the extracellular space, electrolytes, contraindications, and also precautions. So it's contraindicated with hypernatremia. Obviously, if somebody's sodium level is already high, the normal range for sodium is 135 to 145. If let's say a patient is 150, then they're hypernatremic. So you don't want to give the extra sodium in these cases. Also, people who have already fluid retention, such as someone who has heart failure or maybe a renal impairment, you don't want to give sodium because they'll just hold on to more fluids. Use cautiously in surgical clients with those with circulatory insufficiency. They don't have enough circulating volume, hypoprotein protein anemia, people who have low protein in the blood. Be cautious with those patients. I mean, they're already losing fluids anyway because they don't have the oncotic or that colloid pressure that is produced by albumin. So be cautious with sodium. Urinary tract obstruction, heart failure, definitely heart failure and edema, because more fluids will be pulled into the vascular spacing and stress the heart even more because the heart can only handle so much volume. Sodium will cause more volume to enter into the vascular space. Renal impairment, remember that's the job of the kidneys, is to regulate fluid and electrolytes, and also pregnancy category C. All right, so calcium is also in the extracellular space, and as far as contraindications, precautions, and interactions, contraindicated in clients with hypercalcemia or ventricular fibrillation. That's when the ventricles are just quivering. They're not really doing much. Moving at probably about 600 beats per minute, which is a lot. That means you don't have a good cardiac output. Use cautiously in clients with cardiac disease because you don't want to overstress the heart with all that volume that, I'm sorry. I was thinking about sodium, but with calcium, it can depress the heart. So you have to really be careful with that. You know, the low blood pressure and also cause the heart to not beat as strong, right? Because that's what calcium helps the heart muscle to do. It helps it to beat stronger or to squeeze in a more stronger way. When calcium is administered, effect of atenolol is decreased, and it also decreases beta blockade. And so the atenolol is a beta blocker, and so a beta blocker is supposed to lower the blood pressure by dilating the blood vessels, and also it decreases the heart rate. And so if you give calcium with it, it will, the effect of this drug will be decreased. All right, so be careful about giving it together, if at all. Now take a look at some of the different examples of electrolyte solutions. We have the dextrose 5% with normal saline, or what we call D5 normal saline. I will tell you that when you're in the acute care setting, you really need to learn these solutions, because if a bag is running dry, you need to make sure you go and grab the appropriate one. The good thing about it now, of course, is that when you guys go into, especially if you're at a hospital, talking about a hospital now, when you go under the patient's name in the Pyxis medication system, it'll show you the IV fluids for that patient. And then, of course, once you enter the information, the system will open that particular cabinet. But be careful, because sometimes they put different types of IV fluids in those cabinets. So be careful that you grab the right one. Another one is a lactated ringer solution, and also plasma light, which you guys are probably a little more familiar with. Other examples would be your Pedialyte and Rehydrolyte. Let's see if there's anything here. So these are oral electrolyte solutions are most often used to replace loss of electrolytes and fluids and conditions such as severe vomiting and diarrhea. Right. Now your blood plasma, this is the liquid part of the blood that contains water, sugar, electrolytes, fats, gases, proteins, bile, pigment, clotting factors, and it increases blood volume. I don't know what they're saying there during. Let's see what I have written here. So blood plasma is the liquid part of the blood and contains all of what I just mentioned. Human plasma, which is also called human pooled plasma, is obtained from donated blood. So people donate blood in order for them to get that part of the blood, the plasma. Although whole blood must be typed and cross-matched, that's whole blood that contains the blood cells. Plasma does not. The reason being, or this is because it lacks the red blood cells, which determine blood type and Rh factors, right? Remember that that's how we type and cross blood that we're going to give to someone. If we're just talking about plasma, it doesn't have that in it. But if we're talking about packed red blood cells, then we typed and crossed that, and that can cause, um, that can cause reactions, an allergic reaction. So the plasma can be given in acute emergencies before typing and cross-matching happens. So you may need that volume while you're getting the typing cross, in other words, because remember, we need to increase the volume. If someone has lost a lot of blood, we need to increase that volume within the vascular space. Otherwise, they're going into organ failure because they don't have enough volume to keep the blood pressure high enough to help with perfusion. Now, plasma administered IV is used to increase blood volume when severe hemorrhage has occurred. It is necessary partially to restore blood volume while waiting for the whole blood to be typed and cross-matched, or when plasma alone has been lost. That's something you might see in severe burns. So, oh. All right. And that's what plasma looks like here, that kind of golden looking solution. Again, this one, the reason it's this color and not, if it had red blood cells in it, then it would be red. But as you can see, this is the color of plasma. And you don't have to type and cross this one. Type and cross match can take some time, right? And the patient may not have time. And so we want to increase their circulating volume of plasma to improve their blood pressure so that the rest of their organs can live. All right, some of the adverse reactions is fluid overload, as you can see here. So we have to watch for fluid overload when we're giving plasma. All right, contraindications, precautions, and interactions. So blood plasma is contraindicated in clients with hypersensitivity to a component of the solution. Some blood have certain components in it that patients can be allergic to. And so we have to be careful about, we have to know these allergies so that we don't administer the blood to them or the plasma to them. Use cautiously during pregnancy and also lactation, obviously. And no interactions are actually reported. So although I do like to give my blood with normal saline, running at a slow rate, but that keeps it from becoming too thick, and it runs a whole lot easily in my mind. All right. Now your plasma protein fractions, in terms of actions, it maintains plasma colloid osmotic pressure, and also as a carrier of intermediate metabolites in the transport and exchange of tissue products, and it also contains a serum. But let me kind of expound on the part where it says maintain plasma colloid osmotic pressure. Remember, I was telling you that when patients have proteins or albumin within the vascular space, it maintains a certain pressure that keeps that liquid part of our blood in the vascular space. When someone has low proteins or low albumin levels, then that liquid or that plasma part of the blood begins to seep into our interstitial space, causing edema. All right. And where they talk about carrier of intermediate metabolites, protein also acts like a carrier, a transporter. It attaches to certain things, and then it carries it, throughout the body, wherever something is needed, if you will. We do refer to it as, let's see, contains serum albumin and human plasma proteins. All right, so that's what it contains. We use it to treat hypovolemic shock from burns because these patients are losing a lot of fluids. Trauma surgery, again, losing a lot of fluids. Also for infections, especially if someone develops a septic shock, we need that extra volume to help improve the blood pressure. Albumin quickly restores blood volume, especially in the times of loss. Convalescent plasma is used to treat a client with a specific disease, such as COVID. And that's something that's a little rather, I guess, a bit new for me. Let's see if there's anything that I spoke about that. All right. Maybe I'll put that somewhere else. Some of the adverse reactions for plasma protein fractions is urticaria and also hypertensive episodes, especially if they go into an allergic reaction. That causes the blood vessels to dilate significantly. So, but that's a part of the allergic reaction. Ideally, we're giving it to help improve the blood pressure. But if they're allergic to it and they go into an allergic reaction, then you'll have the opposite, meaning the blood vessels will dilate and cause a low blood pressure. All right. So that part about, I guess I should move that over. We'll talk about the COVID. So convalescent plasma is a term used for plasma that is drawn from a client with a specific disease. Once a person has survived viral illnesses like Ebola or COVID, their plasma is full of antibodies to that virus. All right. So it's kind of like you're inoculating or immunizing someone. You're taking the antibodies that they have produced in their bodies and give it to someone else so it can fight an infection. So in an effort to treat clients of a specific viral infection like those above, plasma from an illness survivor or a convalescent client, someone who's convalescing after an illness, is collected and infused into clients with the disease in an effort to build antibody protection. So you're trying to build the one who's now currently ill from these different diseases in order to help improve their immune system by producing antibodies to destroy the virus or the microorganism. So that's what that deals with. And I should have put that somewhere else. Why did I put that there then? What is this here? Yeah, so yeah, I should have put that somewhere else. Anyway, so you know what that is now. I have to work on that later. All right, so in terms of contraindications, precautions, interactions, plasma protein fraction is contraindicated, and those with allergic reactions to albumin, anemia, those who are anemic, as well as cardiac failure, because it can be too much for the cardiac system, too much volume. In the presence of normal or increased intravascular volume. So if the volume, if your intravascular volume is already normal, or if you have too much, you don't want to add more plasma to it because it can cause even more fluid to increase within the vascular space, causing cardiac issues because you're putting more stress on the heart. And clients on cardiopulmonary bypass, some patients who are on these machines, they may be on these machines because they're having a CABG or some other cardiac procedure. And so you don't want to, or it's contraindicated in those patients. Now, it is used cautiously in those who have shock or dehydration, also those with congestive cardiac heart failure. So it appears that you can still give it if they have cardiac issues, but with caution, of course, watching for fluid overload in particular. Also with those with hepatic and renal failure. And do not combine with other solutions or drugs. It has to be given by itself. Now, the plasma expanders, in terms of their action, this is one of the medications we call hetastarch. This is a plasma expander. It expands the vascular space in order to improve circulation, the intravascular volume, the blood pressure, and so forth. We also refer to it as low molecular weight dextran. That's another one. And high molecular weight dextran expands the plasma volume. These are just different types. The hetastarch and the dextran helps to expand the plasma volume. We use it in the treatment of shock caused by burns, hemorrhage, surgery, trauma, and also prophylaxis of venous thrombosis as well. Venous thrombosis and thromboembolism. All right. Now look at the adverse reactions: urticaria, hypotension. This is when they have a reaction to the IV medication. Nausea, vomiting can occur. Headache and fever. Dyspnea, tightness of chest. Again, this is an allergic reaction. Bronchospasm, so the bronchioles in the lungs, they begin to squeeze or spasm, and this decreases airway flow of oxygen, and also wheezing because the smaller alveoli, not alveoli, but the bronchioles become more constricted, all right, and cause wheezing, as well as anaphylactic shock. You don't want to give it for those patients either. But these are the reactions that can occur with this, with the plasma expanders, because the plasma is coming from another human being, right? And so coming from another human being, just like blood, it can cause, a reaction for that patient. The contraindications, precautions, and interactions. Contraindicated with those with hypersensitivity to solution, and also bleeding disorders. You don't want to give it to those with bleeding disorders. Cardiac failure, renal failure with oliguria or anuria. They're just not really putting out much urine at all. So they can go into fluid overload. Use cautiously in clients with renal disease, meaning you can give it, but hopefully they're not in like an end stage renal disease, like stage 4 or 5, but they are producing some urine. Cautiously in clients with a CHF, pulmonary edema, and bleeding disorders. In other words, you can give it to these patients, but you just have to really monitor them. Consult the drug insert prior to combining a plasma expander and any other drug. They usually have this software called Micromedics, and you can look to see, you can enter data to see what is compatible with it. So something to think about. All right. Now, total parenteral nutrition in terms of actions and uses. This is a complex mixture of proteins, fats, glucose, electrolytes, vitamins, minerals, sterile water that are delivered IV to meet a client's nutritional needs. This is that this like steak and potatoes, if you will, of nutrition basically that the patients need. This is the food that they're going to be on for a certain period of time until whatever the reason is, they cannot use the enteral or the GI route of feeding them, then we have to feed them this route instead. All right, to provide nutritional support for a client that cannot eat orally or receive nutrition enterally. Maybe they have an intestinal ileus, an intestinal obstruction, maybe they have a fistula, maybe they have some GI bleeding. Maybe they just had surgery and the bowel sounds has not returned and it's taken a while to return. They could be on opioid medications that actually it impacts the peristalsis. These patients may have to be fed the IV route or the parenteral route until it does prevent nitrogen and weight loss or negative nitrogen balance, which happens during weight loss. Severe weight loss, and so because you're feeding them. All right. Let's see. Some of the reactions here. This might be where I stopped. I don't know if I got this far, but this might be where I stopped. Anyway, adverse reactions, because it is a lot of glucose in this solution, it causes increase in blood glucose levels. It causes glycosuria. Remember, if your glucose levels are increased, it will spill over into the urine. Mental confusion, loss of consciousness, bacterial infection. You know, bacteria loves sugar or glucose. Can also lead to sepsis. Again, um, infections can occur, and they love glucose solutions. It can cause an embolism, especially if you don't there's a portion of the IV called it's called what is it? Like a filter. And I will have to show it to you guys, but it is a filter that we put on the end of the IV tubing. And this TPN is to run in through that filter to filter out any particles, because those particles within that solution, they need to be filtered out because if they get into the vascular system, they can cause an embolism. Also, allergic reactions, let's see, metabolic problems as well, hemothorax and pneumothorax. And basically what that means is that when we insert one of those central lines, let's say near the lungs, like a subclavian central line, the triple lumen catheter, during the insertion process, they can inadvertently or mistakenly puncture the lung and cause hemothorax, meaning blood in the thorax, or pneumo, meaning air in the thoracic cavity or the chest cavity. A lot more details here, of course, that I can't really get into. It's quite a bit. And also, so you guys know, they can add insulin to the solution. We have to also monitor their blood glucose levels every at least 4 to 6 hours, typically every 6 hours. So 612, 612. All right. Let's see. All right. Now, the primary care doctor should be notified if the patient exhibits symptoms of hypoglycemia. So let me say this to you guys. This is very important. When you hang TPN, you have to wean it. And then they also place these patients on this IV solution called D10 normal saline, dextrose 10%. Because if you abruptly DC TPN, these patients can go into hypoglycemia. And you have to know your hypoglycemia signs and symptoms, because we will ask you questions about that. The confusion, the irritability, and weakness, and they may become unconscious, which is more of a late stage, if you will. So make sure you know the signs and symptoms of hypoglycemia. All right. If these patients other symptoms, well, actually I have it here for hypoglycemia: weakness, tremors, diaphoresis, headache, hunger, and also apprehension. You have these feelings of apprehension and so forth. So make sure you guys know that. Do not just abruptly DC TPN. I have here, if TPN must be abruptly withdrawn, say if the IV site went bad, then you have to hang 5 or 10% dextrose in its place and gradually titrate that downward so that they don't go into a hypoglycemic reaction. So really, really, really important. So IV fat emulsion, this is the white stuff that you see here in the picture. It is made from soybean or safflower oil and a mixture of natural triglycerides, so fats, lipids, right? Supplies fat needed for metabolism and also to help cells function, because our cells still do need fats in order to function or survive, just not too much. All right. Uses: prevention or treatment of fatty acid deficiency. And also provided non-protein calories for clients receiving TPN. This is what I was telling you guys about. One of the reasons why we hang lipids with the TPN is so that we want the body to break down or use the lipids for its calories, as opposed to eating up all of its proteins. Because if it eat up all the proteins or uses all the proteins, then healing is much more difficult. All right, so we're sparing the proteins by giving the body an alternative meal to eat, so to speak. All right. Some of the adverse reactions: sepsis, thrombophlebitis, dyspnea, cyanosis, hyperlipidemia, because it is triglyceride based, hypercoagulability, nausea, vomiting, headache, and flushing, increased body temperature and sweating, sleepiness, and chest and back pain. So those are your reactions there. Contraindicated disorders or diseases that interfere with normal fat metabolism, such as acute pancreatitis. Remember, with acute pancreatitis, you're probably not producing enough lipase. Probably need to do this if somebody has issues with bile, right? Because you need bile. Well, actually, if you don't have enough bile, then the fats will just go through the system anyway. So, because it's not emulsified or broken down by bile. But lipase is needed by the pancreas to break down fats as well. And with pancreatitis, you don't have that or very little. Egg allergies, be careful. It's contraindicated with those with egg allergies. Use cautiously in patients with renal disease, heart failure, pulmonary disease, anemia, blood coagulation disorders, edema, bleeding disorders, and also those who are pregnant. It is a category C. In general, fat emulsions should not be combined with any other solution or drug except when the drug is already combined in TPN. We do add some drugs in TPN, and you can give it together in that instance. But typically, we give it. We can infuse the lipids in like a Y connecting way with the TPN. But be careful about what drugs you add to it. Usually it's given alone. So it's a separate line that we administer it through. Let's see, what is that? Already comes with it. All right, gonna skip that. Acid-base imbalances and alkalinizing and acidifying drugs. So metabolic acidosis, so there's a decrease in blood pH level below 7.35, and that is caused by an excess of hydrogen ions in the extracellular fluid. And so we treat it with alkalinizing drugs. If you're too acid, we want to push you in the other direction, right? If you're like 7.2, we want to push you towards that 7.35 with base or alkalinizing drugs. Now, metabolic alkalosis, so this is an increase in the blood's pH that is caused by an excessive amount of bicarb in the extracellular space. So you've basically gone the other direction. And we treat this with acidifying drugs. So we're trying to push these, the patient's levels to the left, whereas when someone is in acidosis, we're trying to push that number to the right, or those values to the right. Because remember, the idea is to get them between 7.35 and 7.45. Sodium bicarb is the alkalinizing agent. It separates in the blood, and the bicarbonate functions as a buffer to decrease the hydrogen ion concentration and raise the blood pH. So basically, what bicarb does is when someone has too much hydrogen ions, meaning they're acidic or acidemia, basically the bicarb is a buffer, and it helps to decrease those hydrogen ions, making the patient again go back towards that normal direction of 7.35 to 7.45. Also, a gastric and urinary alkalinizer is used as well to try to make the patient a little more towards base. Remember, our blood is already more slightly base, all right, because 7 is neutral, less than 7 is acidic, a little greater than a 7 is a base. And so our normal blood pH is 7.35 to 7.45. Right. And so, all right, so used to treat metabolic acidosis and also increase blood pH via IV. And that's what we're trying to achieve here, trying to increase the pH from that 7.20, which is acidic. Gastric upset and antacids, the oral route. Also, we use it to treat severe diarrhea accompanied by bicarbonate loss. And we give it orally. In other words, when someone has diarrhea, you're losing a lot of base. So the patient can become acidotic. When someone is storing up or they have an NG tube in the stomach, they're pulling out the hydrochloric acid. So those patients can become more base. All right. In this case of severe diarrhea, you're losing all that base, meaning these patients can become more acidotic. And so we're giving the oral bicarbonate in order to improve the acid base balance. All right, I think we're getting kind of close, people. So let's see. Adverse reactions, nausea, vomiting, and pain, discomfort, symptoms of indigestion and gas. Now, prolonged use of oral sodium bicarbonate results in systemic alkalosis because you're taking this drug so much, you become more base, more alkalotic. And so that's not a good thing either. Now, in some instances, excessive oral use of bicarbonate may cause the nausea, vomiting, as I mentioned. Some individuals use like baking soda to relieve GI disturbances such as pain and discomfort, symptoms of indigestion and also gas. And so when they're using it for too long, they can become more base, or their blood it becomes more base, and that's not good. In terms of alkalinizing drugs, bicarbonate, as far as interactions, the oral administration of bicarb may decrease the absorption of ketoconazole. So one of the, I think, isn't that for the fungal infection? So it can decrease the absorption of this drug. So in other words, the anti-infective is not as effective. Administering bicarb causes increased levels of quinidine, which is a cardiac medication. Flecainide is the cardiac medication, and the symptomomimetics. In other words, there's certain drugs that mimics the sympathetic nervous system, so that fight or flight type of reaction. And so bicarb will cause an increase in these levels, and of course, you don't want that, right? Especially the quinidine and the flecainide, because it can cause more cardiac dysrhythmias. These are antidysrhythmic medications, of course, the quinidine and the flecainide. Increased risk of crystalluria with fluoroquinolines, possible decreased effects of lithium, patients on lithium for psychotic issues, methotrexate for those with immune issues, or I think even cancer, if I'm not mistaken, and chloropropamide as well. Remember, these patients have to drink lots of fluids with a crystalluria in order to prevent stone formation and increase risks. All right. So as far as interactions continues, bicarbonates are contraindicated in clients losing chloride with metabolic or respiratory alkalosis. You don't want to increase the base. With hypokalemia, with renal failure, with abdominal pain, and also sodium-restricted diets. Must be used cautiously in those with heart failure, renal impairment, and those with glucocorticoid therapy, steroid, in other words, a type of hormone, and also during pregnancy. Now, administering bicarbonate causes increased levels of quinidine. So we talked about all that. I don't know why these pages seem to be off for me. This could have been one of those times where I actually rushed to do this. So forgive me. I have to go back and adjust some of this. But we talked about that already. Now, the acidifying drugs, what we call ammonium chloride, the actions and uses. So ammonium chloride lowers the blood pH by being metabolized first into urea, and then into hydrochloric acid, all right, which is further metabolized to hydrogen ions in order to acidify the blood. Because remember, these patients are they're more alkalinic, all right, so they have more, their blood is more alkaline based. And so what you're trying to do is create more hydrogen ions in order to push them back the other direction. You're not trying to make them acidic. You're trying to just push that um, value again, because remember, when you're looking at 7.35 to 7.45, if you're to the left of it, you're more acidic. If you're to the right of that 7.45, you're more base. These patients are to the left of, they're to the right of the 7.45, so they're more based. And so what we're trying to do is to create more hydrochloric acid, and which is metabolized into hydrogen ions when it's broken down, and this will acidify the blood, so you get to move it to the left, more towards the 7.35 to 7.45. Hopefully that makes sense. So we use it to treat metabolic alkalosis from excessive vomiting, because remember, when you're vomiting hydrochloric acid from the stomach, so they become more alkalotic. Overuse of diuretics, because when you are peeing a lot with diuretics, you're peeing a lot of the hydrogen ions, and these patients become alkalinic as a result of that. And so we use this drug, because they are alkalinic. We're trying to push them back towards that normal range. And also too much alcohol or antacid use as well, which can cause alkalosis as well. Excuse me. Oh, I see light at the end of the tunnel, I think. Adverse reactions, metabolic acidosis, or it can cause these acidifying drugs, ammonium chloride, can cause metabolic acidosis, meaning it's going other direction, but it's going too much to the other direction. Loss of electrolytes, and also especially potassium. Now, what I want you to take a look at symptoms of acidosis. This is what I was telling you about. When a person becomes acidotic, it can have a more depressive effect on the body. Look at what it does to the central nervous system here. The headache, the sleepiness, confusion, loss of consciousness, and coma, and what have you. It kind of affects each of the systems here. I don't know about that high heart rate. Usually it causes bradycardia. Maybe that's what it does initially, though. Administering ammonium chloride and spironolactone may increase systemic acidosis. I think this is because, let's see. So when the blood becomes more acidic, and you're taking this spironolactone, this is this potassium sparing diuretic. All right. What happens if I'm not mistaken, and I have to go back and clarify this, but I believe the hydrogen ions inside of the cells, well, the hydrogen ions on the outside of the cells, and you have this potassium inside the cells normally are intracellular. And so when someone's blood becomes more acidotic, they switch places. And so the potassium would go on the inside of the cells, and I may have this reversed, and the potassium, potassium goes inside the cell, and the hydrogen the hydrogen ions, or essentially the hydrogen ions comes on the outside, and this could make the blood system more acidic, because they switch places. They're trying to maintain what we call electrical neutrality, right? So they switch places to try to create a kind of equilibrium. You can't have more on one side and less on the other, but the body tries to equilibrate or make it equal. So I think that's what this is talking about. I wish I had done a little more research on this before, but just thinking about it from what I know, you have to be really careful, because again, that the fact that you're taking spironolactone, you're going to hold on to more potassium. And so both of those elements, they're going to switch places. And the hydrogen ions will be more on the outside of the cell, and potassium will go on the inside to try to hide the potassium in order to try to lower it. More hydrogen ions in the extracellular space or the serum space leads to more acidosis. I'm going to look that up, and then I'll talk to you all about it later on. Let's see, contraindications for fat emotion. Fat emotions are contraindicated in clients losing chloride. I don't know why it seems like I went over this already. Yeah, I think I went over this already, so I won't go over this again. For some reason, these slides seem to be out of order. Just because it comes from the publisher doesn't mean that you have to accept them as perfect, and you have to really analyze these things. All right, so this is the pre-admission assessment piece. So I won't go over these or this piece, but I think we should be good to go at this point. I'm going to go ahead and get this out to you all as soon as possible, so that you have this to hopefully study. Yeah, you have this to study for your exam. So let me go ahead and get this out to you. This was an hour and 14 minutes, not that long. And if you, use the speed function in YouTube, you can probably make it in half an hour, maybe 40 minutes or so, kind of get through it quickly. And I'll let you guys know that. All right. And I appreciate you. Thank you.